Now we are going to case number 5. There is a lot of necrosis and uniform cells, and some of these cells are pleomorphic. And when you do the differential diagnosis, here is a DCIS and pleomorphic LCIS. And when you do E-cadherin is totally negative. In DCIS, it has to be positive. Here it is negative. And here you can see two population of cells. These are the preserved ductal cells, and these are pagetoid spread of the lobular cells. And this is the E-cadherin. The ductal cells are taking E-cadherin, whereas the lesional lobular in situ cells are not taking. See, the diagnosis is pleomorphic LCIS. So what are all the terminologies we use in lobular proliferation? ALH, atypical lobular hyperplasia, classic LCIS, florid LCIS, and pleomorphic LCIS. These are all the 4 major members of the LCIS. And whenever there is proliferation involving a lobule less than 50% of the terminal ductolobular unit, it is ALH. When it is expanding more than 50% of the lobules, then it is classic LCIS. This expansion is extending without any stroma between, or large expansion occupying more or less one low power field, then we call it florid LCIS. You have to know the difference. In DCIS, florid means extensive area of DCIS, whereas in LCIS, this is the criteria. It is not extensive. It may be one focus, but there is no stroma. We will see some pictures. When you see pictures, you will remember that. In pleomorphic LCIS, you have to see pleomorphism, and the definition of pleomorphism in any organ is more than 4 times the size of lymphocytic nucleus or the smallest cells in the lesion. So these are all the main difference in the 4 members of lobular proliferation. See here, you see this is one lobule. This is one lobule. This is one duct. You can see the ductal epithelial cells, and LCIS is having pagetoid pattern. And here you see this is lobule is preserved, this lobule is preserved, this is preserved. Less than 50% only shows expansion of the lobules, and there is a lot of stroma in between. Okay, so less than 50% of the lobular involvement is ALH. Whereas here you can see the whole lobule is involved. More than 50% or almost like 99%. Probably this lobule is not involved. Part of this acini is not involved. So this is LCIS. So less than 50% is ALH and more than 50% is classic LCIS. And you see the stroma. Okay. So that is very, very important. In case of florid LCIS, the stroma will be lost. In a classic LCIS, you can see 2 types of cells, small cells and large cells. Small cells are known as type A cells and larger cells are known as type B cells. And when you see small cells, they are very uniform. This is like a bag of marble appearance. And this composite picture tells you the difference between classic, florid, and pleomorphic LCIS. See the classic LCIS, more than 50% of the lobules are involved. And but the stroma is present in between the dilated acini. Whereas here, the florid, this is one lobule, you never see any stroma. The acini are markedly distended, okay? And they are very large. No stroma in between the acini. So this is florid. Whereas here, take the smallest cell and take the largest cell, the nuclear difference is more than 4 times the size. So this is a pleomorphic LCIS. Take a picture of this. I don't have camera here, I think, but picture will be very, very useful to differentiate this. The other types of LCIS are signet cell, apocrine, and comido with calcification. Previously, we thought comido is very, very specific for DCIS, but now we can see it in LCIS also. There are ways to differentiate. I will show you in a minute. This is pleomorphic DCIS. This is again apocrine, and this is cytoplasmic lumina in LCIS. So how will you differentiate DCIS and LCIS? See here, the cribriforming is very, very important, and they will show nuclear variation in size shape, whereas here they will be classic, they will be more monomorphic, and they are confined within the lobules, whereas here they are extending into the ducts. And in high power, we already saw 3 nuclear grades, whereas in a classic LCIS, this is mainly DCIS and classic LCIS. You can see monomorphism of the cells, and IHC is very, very important. Okay, E-cadherin. E-cadherin will be totally negative in LCIS. That brings the role of IHC. There are 3 markers you have to remember: E-cadherin, P120, and beta-catenin. E-cadherin will be all of these markers will be having membranous staining in DCIS or infiltrating ductal carcinoma, whereas E-cadherin will be absent in lobular neoplasia, and P120 will be cytoplasmic staining. Here you can see the example. This is a lobular carcinoma. E-cadherin is lost. P120 is showing cytoplasmic staining. It is not taking membranous staining, and beta-catenin will be negative. Here, this is a lesion where you see DCIS and LCIS. E-cadherin is preserved in DCIS, whereas lost in LCIS. The myoepithelial cells may take up the E-cadherin, that you should not take it as positive. The proliferating cells are negative. So this is LCIS. Again, this is DCIS and LCIS in the same patient. And the LCIS can also show comedonecrosis. But when you look at the cells at the junction of necrosis and the viability, these cell borders are not very distinct. Whereas here in DCIS, the cell borders are very distinct. That way, whenever you see comedonecrosis, you see at the junction to differentiate LCIS and DCIS. But you can do the markers. The E-cadherin is positive in DCIS, whereas it is negative in LCIS. Some more picture. I love this DC-cadherin and P120. See here again LCIS, E-cadherin negative, DCIS, membranous positivity, P20, cytoplasmic staining in LCIS and membranous staining in DCIS. Here, interestingly, in the same duct, you see 2 lesions, ductal and lobular. And when you do E-cadherin, membranous staining is preserved in ductal component, whereas absent in the lobular. So that IHC is very, very important to differentiate LCIS and DCIS, and that's very important for a lot of treatment decisions. Now we are moving to case number 6. Lot of necrosis. Whenever I see this, I will think of DCIS first, and lot of cells in the background and lot of lymphocytes here. Okay, and see this epithelial proliferation here. These are more into lobules. So they look, this area looks more like lobular. This area looks more like ductal. And see these cells, individual cells, they are pleomorphic and they are arranged in cords of cells. Okay, so this is a pleomorphic lobular carcinoma with the classic and pleomorphic LCIS. And that brings the types of LCIS. It can be classic, can be histiocytoid, it can be alveolar pattern, or it can be signet cell pattern, can be pleomorphic, or it can be solid. These are all the 6 main types of lobular carcinoma. Coming to case number 7, you can see lymphoid infiltrate. High power shows a lot of atypical cells. You can see one atypical mitosis. Again, a lot of lymphoid cells. Remember, this type of tumors we have to do PD1 and PDL1. And this is very classic of what we used to call medullary carcinoma. So this is an invasive breast carcinoma NST with a medullary pattern. And the other patterns of infiltrating carcinomas are lipid-rich, oncocytic, glycogenated, carcinoma with scattered osteoclast, pleomorphic infiltrating breast carcinoma, or histiocytoid. This brings the molecular classification of breast carcinoma, IHC based. Mainly it is luminal, HER2 new, and triple negative. Life is very simple when it is only like this. And how do you come across or type these by IHC? You do ERPR and you do Ki67 and HER2 new. Okay. Luminal is ERPR positive, HER2 new is HER2 positive, triple negative, all the markers are negative. That is the very simple. So subtype is depending upon ERPR, HER2 new, Ki67, CK5 and EGFR to differentiate triple negative. So triple negative, all the ERPR, HER2 new negative, Ki67 can be any. In non-classified basal carcinoma, both CK5 and EGFR will also be negative. Whereas basal-like breast carcinoma, the EGFR and the CK5 will be positive, but ERPR, HER2 new will be negative. In HER2 new, only HER2 will be positive. Okay, so this is very easy. Coming to luminal type A, ERPR positive and Ki67 less than 14%. In luminal B, depends upon what is the number of PR positive and what is the number of Ki67 positive. When PR is more than 20 and Ki67 is more than 14, it is luminal type B with Ki67 more than 14%, because these tumors react worse when compared to luminal A because of the high proliferation index. When the progesterone receptor is less than 20, again these tumors behave differently. That's why they classify the luminal B depending upon the number of progesterone receptor positive. And HER2 new, it can be only HER2 new positive, or it can have both ERPR positive. It's like a triple positive. So that they divide into HER2 new luminal markers positive. And here HER2 new ER positive and PR is negative. So whenever HER2 new positive, is it only HER2 new or other markers are also positive? So this is the simplest way we classify the breast cancer by IHC. And the triple negative lesions, morphologically, we can guess some of them are non-neoplastic. For example, microglandular adenosis and atypical microglandular adenosis are triple negative. Adenomyoepithelioma, a benign tumor, is triple negative. And when come to malignancy, low grade and high grade, some members of low grade, for example, adenoid cystic carcinoma, salivary gland tumors that happens in the breast, they are all of low grade, but they are triple negative. So you cannot categorically say triple negative is bad. So only a couple of them are high grade, which are having bad prognosis, whereas a couple of them are either it can be low grade or non-neoplastic or benign. Molecularly, how these triple negative lesions are classified? They are classified into basal-like type 1, basal-like type 2, immune modulatory, mesenchymal stem cells, mesenchymal type of cells, and mesenchymal stem cells, and luminal androgen receptor. Okay, again this is grouped into 4: basal-like, immune activated, basal-like, immune suppressed, mesenchymal, and luminal androgen receptor positive. So this is the new molecular typing, but multiple omics, you know, proteomics, metabolomics, they are also there. So multiple omic approach is on the way, but this is the current, you take a picture of this. And why it is important? Because of the potential targets. Immunomodulatory, you have to use immune checkpoints, basal-like, platinum-based or PRP inhibitor. Mesenchymal, it is EZH2 inhibitor or targeting the stem cells. Luminal androgen, AR inhibitor. Okay, so that's why it is very, very important to know the molecular classification. And tumor infiltrating lymphocytes are getting more and more importance, because you know the immune tumor microenvironment is very important in determining And there are 4 patterns: immune deserted, margin restricted, soma restricted, and fully inflamed. For example, here it is breast carcinoma and adjacent normal. In immune deserted, you don't see the lymphocytes. There are only very few lymphocytes. Whereas in margin restricted, you see number of lymphocytes in the margins. Nothing in the stroma or in the primary tumor or in the benign background. In the stroma restricted, the lymphocytes are in the stroma, not affecting the epithelial malignant proliferating cells. Whereas in fully inflamed, it is there in the margin, it is there in the stroma, it is there in the epithelial cells also. So this is very, very important, and people are working how to report these things. Grading systems are on the way, and this is very important in targeted treatment. For example, when it is fully inflamed, it is very good prognosis, and you can use immune checkpoint inhibitors in that. I told you salivary gland-like tumors can happen in the breast. They can again divided into benign and malignant, and they have specific molecular findings. You're moving to case number 8, well-circumscribed tumor. And here you see some of the cells are having eosinophilic cytoplasm. Some of the cells are having vacuolated cytoplasm, and here you can see 2 types of cells. These are epithelium, these are myoepithelial. So it is a combination of epithelial and myoepithelial. So it is known as adenomyoepithelioma benign. And when you do P63, all the myoepithelial cell will take up, whereas the epithelial cells will be negative. And again, this is a spectrum. Adenomyoepithelioma benign, atypical, and malignant. Here the mitosis is very, very important. 3 to 10 is atypical, less than that is benign, and more than that is malignant.